postural orthostatic tachycardic syndrome or dysautonomia are not functional neurologic disorders. We're going to dissect this argument. We're going to talk about it. There is a brand new paper out about this, and I think it's really, really important for us as clinicians to understand the diagnostic criteria and be able to tease apart these conditions. So if you are joining me live, I see a lot of you here. Hey, Stella. Hi, Julia. Thanks so much for joining me. This is a very hot topic. If we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist. I am the owner and founder of Reactive Therapy and Wellness in the Los Angeles area. We run a functional neurologic disorder program. We also run a POTS program. We are a center of excellence for EDS or Ehlers-Danlos syndrome. So this particular article really caught my eye because these are disorders that I see a lot. We see POTS, we see FND, we see Ehlers-Danlos syndrome. Sometimes we see all of those together, or we might see them separately. And if you don't know this, I also teach neuropathology at the University of Southern California for the Doctor of Physical Therapy program. I am very passionate about getting a diagnosis right. Screening and differential diagnosis are things that are very important to me. So I, alongside the authors that wrote this article, really feel strongly that we get it right. And while as physical therapists, we're not providing a diagnosis, we should be screening very thoroughly when somebody comes in with a diagnosis. If they don't meet the diagnostic criteria or if they have other signs and symptoms, we should be screening and referring because the treatment depends on it, right? So I just want to say welcome. I saw a vestibular neuro PT from Argentina. So I just wanted to say hello. Thanks so much for joining today. And I also just want to say, hey, I'm going to try to answer your questions and get to all of these tonight. But if I miss something, I will keep sharing in our stories. I shared a bunch of articles, by the way, in my stories today. And I'm going to share a lot today while we go live as well. And I will put all of the links in our newsletter that I send out every week. I send out a newsletter to clinicians every Friday, and you can sign up at reactiveeducation.com, and a newsletter to patients every Monday. You can sign up at reactivept.com. Shira is also saying, I was recently shown an article that claimed FND and POTS couldn't be comorbid, and this really confused me. What are your thoughts on that? Great question. And I will tell you, absolutely, I see these at the same time quite frequently. In fact, I did a quick look at our data, and 15% of the people in our FND program also self-identify as having POTS. Now, in the literature, as the authors talk about in this particular study, it might not be as common. We tend to see more complex cases. So I think at Reactive, we tend to see people with multiple diagnoses. But absolutely, as with many disorders, you could have POTS and a stroke. You could have hypermobility, Ehlers-Danlos syndrome, and cerebral palsy, right? So you can have many disorders at the same time. There's no reason that you couldn't have both. But it is important to not put POTS or dysautonomia as an FND. It is not a functional neurologic disorder. And that is what they talked about in this paper. So here's the paper. It was in just November, so this is hot off the press, Frontiers in Neurology. It's called POTS, Postural Orthostatic Tachycardic Syndrome, and Other Autonomic Disorders Are Not Functional Neurologic Disorder. written by a great group. I will just say Todd Davenport, I'm going to give him a shout out. He did his orthopedic residency at the same time I did my neurologic residency at USC, so we go way back. But let's talk about this. So this was an opinion piece that these authors put out really to dispel a myth. And what they talked about is that sometimes folks might get misdiagnosed. And I will say, yes, I can see that people get misdiagnosed. I will tell you in our practice, what we see most commonly from a misdiagnosis or a lack of diagnosis is that somebody might have a functional neurologic disorder, but we go through screening and we can clearly see they meet the diagnostic criteria for POTS and they hadn't been diagnosed. So they have FND and POTS, and we screen them and refer them so they can get the diagnosis. So this is really important. The authors start off in the introduction that there have been some reviews that maybe have suggested that POTS was a functional neurologic disorder. I do not agree with that. POTS is clear diagnostic criteria. It's not a functional neurologic disorder. Also, similarly, some from this group have also published a paper in a similar vein. Long COVID is not FND. Also, I agree, long COVID also is not FND. Could you have long COVID and FND? Possibly. Could you also have long COVID and POTS? Yes, long COVID is not POTS. Are there things that might go together? Yes, and the authors talk about this. For example, Ehlers-Danlos or hypermobility spectrum disorders can go hand in hand with POTS. We need to screen both of them. I see a question here, and I'm going to talk about this, and I'll share this from a table in this paper, the difference between dysautonomia and POTS. And dysautonomia is a broad umbrella. It's not a diagnosis. It's an umbrella. It frankly, like Latin just means dysfunction of your autonomic nervous system. So that can be many things. The authors in this paper actually really nicely give a very simple table, and I'm going to share it right here, of these diagnostic criteria. I love a good article with very simple table with diagnostic criteria. Now, I know you can't really read it, but this article is available free full text. I'll include it in our newsletter. But they have the very clear diagnostic criteria for POTS. That's at the top. These are different types of autonomic disorders. POTS at the top, neurocardiogenic syncope, NCS, OH, orthostatic hypotension. Down below that, I'm looking at it on my computer here too, IST, inappropriate sinus tachycardia. And then at the bottom, they have FND, so that we can differentiate. These disorders have very distinct diagnostic criteria. So, and I'm going to be really honest, I have dysautonomia. I have orthostatic hypotension. It's really bad right now. Not gonna lie, I've got all my compression and all of those things. So this is an area that personally I have dealt with as well. I do not have POTS, but here are the diagnostic criteria. For POTS, we can do a screen. By the way, you could do the active stand test. It's really simple. I advocate for every clinician to know and understand the screening for POTS, as well as orthostatic hypotension. As a neurologic physical therapist, we screen for these things all of the time because they are common in other neurologic disorders, like Parkinson's disease, like spinal cord injury. So this is not new if you're a neurophysical therapist. But let's go through the diagnostic criteria for POTS. First is this heart rate increase greater than 30 beats per minute within 10 minutes of standing. This is for adults. It's greater than 40 for adolescents. And so the TTT, by the way, is a tilt table test. I don't do a tilt table test. I don't have a tilt table, but we do an active stand test. You have this tachycardia in standing in the absence of a drop in blood pressure. So the absence of orthostatic hypotension. There's the symptoms of this intolerance are greater than 3 months. So it's not just a short-term thing, like you were dehydrated one day or something like that. And that is the fourth criteria, that's exclusion of these other things, such as dehydration, medication, or other medical conditions. So that is POTS. Those are not the diagnostic criteria for FND, right? So POTS, very clear. And then I won't go through all of these, but you can see they have very clear diagnostic criteria. And so does FND. FND has very clear diagnostic criteria. Here's where things can go wrong is, let me stop sharing this, and I'm going to choose a different piece just to give you a resource. This is a fabulous article that all physicians should be looking at to diagnose FND, because FND, like other neurologic disorders, is a clinical diagnosis. It has very clear, reproducible, sensitive, and specific positive clinical findings. People should not be labeled with FND just because they ruled out other things, or just because a doctor didn't know, or, as some people have said, kind of thrown in a wastebasket of FND. I don't believe in the wastebasket. I believe in positive clinical signs, and so do neurologists who are well informed. This is a really great article. I'll share it in our newsletter, but I will just show you just a quick peek. There are many signs, like I'll show you. There are 4 pages of tables of different clinical signs that have been validated to support a diagnosis of a functional neurologic disorders. None of these are autonomic. None of these are the same as POTS or orthostatic hypotension. These are specific to FND. And a person, if they've been diagnosed with FND, should have gone through a process just like a person who had ALS or Parkinson's or dementia or migraine. Very specific testing to rule in that diagnosis. No difference. And I think this is where the authors are writing this, like, people should go, if they're having some unusual symptoms. Unusual or weird does not equal FND. If they are having any symptoms that are kind of screaming autonomic nervous system, your heart rate racing, feeling faint, maybe even passing out, maybe even having tremors, those do not equal FND. FND has very specific positive signs for tremor that would not be positive in POTS, right? So I think what can happen is, if a person doesn't have a knowledgeable neurologist doing this testing, it's possible for them to end up in the bucket of FND when what they have is POTS. However, if they have positive clinical signs of FND, they might actually have FND and POTS. And I say that because I see it. So I'm going to pause for a moment. We have I have a lot more to cover in this article because it's really good, and also it's a quick read. It's short, but I see some questions. I was diagnosed with FND triggered by COVID. How would that be separate from long COVID, or would that count as both? That is a great question, and this is where I think people can get confused with FND. FND could be triggered or secondary or comorbid with another neurologic condition. So yes, now I don't know for sure if your FND was triggered by COVID, but we do know that functional neurologic disorders can be triggered after an infection, some sort of inflammatory event, injury, a broken bone, surgery. We can see the brain changes that occur in FND could happen after one of those events. So that's why, yeah, you could have developed FND after an infection, not just COVID, but any kind of infection. But you could also develop FND after other things. It's not always post-infection. Now, there are, long COVID does exist. So you could also have long COVID and FND side by side, but I wouldn't call it FND unless it met those positive clinical criteria. So for example, if you would have tremor, there is a test for tremor in FND that is sensitive and specific to FND. If you had long COVID and tremor, it's going to be different unless it was FND, and you would have positive clinical signs of that. So absolutely, I am a both and person, right? So I think, because I see this all the time in clinical practice, that people can have more than one thing. I would never put all of a person's symptoms. Let's say a person comes to me with FND and they're sharing these intermittent headaches that sound like migraine. I'm not putting that in the FND bucket. That's migraine. Just like when they come to me and they share with me that their heart rate is racing when they stand up, I'm going to do an active stand test. And yeah, they might meet the criteria for POTS. I'm not going to call that FND because it's not. It is POTS. Another question was, does BCTT work with POTS? You're going to have to spell that out for me because I'm not sure what BCTT is. Great question. Active stand test is the same as the NASA lean test. I'm less familiar with the NASA lean test, but they are similar. We tend to do the active stand test. And somebody else is saying this is literally what happened to me. One functional chiropractor diagnosed me with this, but I definitely don't have that. I have nervous system dysregulation post a TBI. This is another disorder. So again, I'm just going to share where we're coming from. We run a concussion and TBI program, right? And some folks have post-concussion symptoms, and they might also have FND, but not always, right? So again, this, I think from reactive standpoint, from my clinical standpoint, these are all subspecialty disorders. At reactive, we happen to specialize in a lot of these disorders. We've got a big group. We've got specialists in all of these areas. We have different people that lead different programs of each of these. So I come with a very unique perspective, and I'm going to admit that in a lot of healthcare, these things are siloed and separated, right? At reactive, they're under one roof. Do we treat them all the same? No. Are they different? Yes. Do we have to screen and assess for these things? Absolutely. Absolutely we do. Is there overlap with some of these things? Yes. Like you mentioned, nervous system dysregulation might be a part of what develops in POTS. You might see it after concussion. You might see it in FND. You might see it in a pain disorder. Here's the good news and bottom line. Those things are treatable, right? That is treatable. And the lesson that I would take, and this group advocates for this as well, whole person approach. We should not just be treating a diagnosis. We should not even be accepting that the diagnosis is the one true thing, that there might not be other things. But if we zoom out and look at a whole person, their life, their environment, what they want to do, what they love, and look at all of their underlying symptoms and systems, we should treat that all together. And we should not put things in boxes that they shouldn't be in. So for example, we shouldn't put POTS in the FND box. So going back to this paper, and again, let me just pull it up here just because I highly recommend it for folks. It has a really good distinction. Again, the first part of it, they talk about POTS and dysautonomia having distinct diagnostic criteria. So I reviewed that diagnostic criteria, and I reviewed there is distinct diagnostic criteria for FND. A person shouldn't be diagnosed with FND without meeting those diagnostic criteria. The second part in here, actually, is it the second part? It's not the second part, but it's towards the end, but let me hit on this part. autonomic disorders versus autonomic symptoms. I love that they talked about this. So there's autonomic disorders like POTS, like orthostatic hypotension. And then there are autonomic symptoms, and they're not the same. So an autonomic symptom may be that your heart rate runs high, or your heart rate variability is low, or that you get very hot, or maybe that your pupils remain dilated. That doesn't mean you have POTS. It is an autonomic symptom, just like we can have sensory symptoms or motor symptoms. It doesn't mean that you have a neuropathy in your autonomic nervous system, although it could, and we should screen for that. But having a symptom doesn't equal a disorder. And I love that they talked about this, because we recognize in functional neurologic disorders, people might have autonomic symptoms. It doesn't mean they have POTS or dysautonomia. And I had to bring this paper in just to share this with you. Let's see if I can find it. Yes. Another really nice systematic review that looked at autonomic, endocrine, and inflammation profiles in people with FND. And this systematic review and meta-analysis found that yes, people with FND might have autonomic symptoms. Two of the things that come up: lowered heart rate variability or an elevated resting heart rate. There are also some particular patterns that are seen with functional seizures. This is really helpful because a person with dysautonomia could have an anoxic seizure, and we can clearly differentiate that from a functional seizure. They are very clearly different. And heart rate is actually part of that. But the whole pattern is different as well. There's so much we could talk about seizures. That's for another day. But if you are a clinician and you're working with people with FND, you also don't want to say that they have POTS and they don't have POTS. They need to meet the diagnostic criteria for POTS. They might have autonomic symptoms. And now here's where I would tell you, here's the good news. Maybe you're a clinician going, oh my gosh, this is a lot that I'm screening and it's kind of overwhelming. The good news is that your treatment approach can be similar. And this is actually something I might disagree in this article, because I think actually they say that the treatment is vastly different. And maybe this is because I just see a lot of autonomic symptoms in general across the board of neurologic disorders that, yes, do I have specific things that I'm screening and training and treating in POTS versus FND? Yes. However, for both, that whole person approach where we are looking at nervous system regulation, we're training the autonomic nervous system, we might be doing a graded exercise or activity, or maybe not. If they have post-exertional malaise, I'm holding back on that piece as well. We look at lifestyle, we do pacing, we look at the environmental and contextual factors. We might use compression. We released our brand new guide for people with POTS and EDS, all about compression. So actually, I would say there are pieces that overlap in the treatment that could be very helpful for both disorders. I think that's actually a good news. Now, here is the thing that they argue in this paper, and I agree. A person with FND who doesn't also have POTS, their activity tolerance might be higher. We might not have to monitor heart rate as much in our exercise progression. However, I would say I monitor heart rate and exercise progression for everybody. Like, I don't care their diagnosis. Heart rate's important if they've had a stroke, if they have Parkinson's disease. So maybe that's just the neuro PT in me, but I'm monitoring heart rate no matter what. I'm doing some sort of graded exercise no matter what. But I recognize not everybody's a neuro PT. So for the general population, yes, we cannot be, starting a running program right away in a person with POTS. And maybe a person with FND who's a runner, we'd be able to do that. So that is a very clear distinction. So let me stop sharing that particular article. One of the other things that they address in this article are the common comorbidities of POTS. So these comorbidities, by the way, are actually very similar to FND. Migraine is one of the top comorbid conditions with FND. It is not FND and it is not POTS. It's a distinct thing. It just happens to coexist with both of those. Migraines, gastrointestinal disorder, small fiber neuropathy, Ehlers-Danlos syndrome, and hypermobility spectrum disorder. They quote at least 30% of people with POTS have this. And several articles recently have come out to show how common hypermobility is in people with FND, and vice versa, how common functional symptoms are in people with hypermobility disorders. We need to screen for all of these, and we need to treat. We need to support the person with a hypermobility disorder. We need to treat their POTS. If they have mast cell activation, this is another comorbid condition that we see with POTS, we see with EDS, we also can see it with FND, and there are treatments that can be done and are really beneficial for people. So we need to screen for the presence of this. Absolutely. So I want to make sure I hit on all of the pieces from here. First, diagnostic criteria, clearly different between POTS and FND. The common comorbidities, actually, they're pretty similar between POTS and FND. It doesn't make them the same. But in the published studies, POTS does not come up as a common comorbid condition with FND. As I mentioned, in our program, 15% of our folks in our FND program also self-report POTS. That is higher than what we're seeing in the published data. But I think that's important to consider. Autonomic symptoms do not equal an autonomic disorder. And the bottom of line of treatment, regardless, is zooming out and taking in the whole picture of the person. If a person comes to you with FND, I hope you confirm the diagnosis through some positive clinical findings. And if a person has new symptoms, that you do not assume that those are FND. If they're having headaches, it could be a headache syndrome. It could be migraine. If they're having tachycardia, like, you should be screening for POTS, right? So I think what can be problematic is if we put everything in one bucket. Now, I'm going to go back up here and just make sure I didn't miss. I saw a couple things come through, and I want to acknowledge your comments. Someone else said, I have FND, diagnosed in 2023. Sure said, I found diagnosed via exclusion. Yes, so this is challenging, right? So I've heard this before too. FND, as well as other disorders, are not solely based on exclusion. Like you do every test under the sun and they're normal and therefore you have FND. No. Absolutely not. That is not acceptable. There are positive signs. And there are a growing number of clinicians who do understand FND. And so if that has been your experience, I would recommend go to the FND Hope website, look for clinicians that understand it, and ask for a positive diagnosis. I think it is deserved. Oh, another question, FND triggered by a craniotomy. That's interesting. I'm not sure that I've seen that before. Doesn't mean it doesn't exist, but I'll tell you, in the literature in functional neurologic disorders, we can see FND triggered or alongside other neurologic disorders, multiple sclerosis, Parkinson's disease, tic disorders, tremor disorders, for example. I talk about this in a lot of my other videos. I won't talk about it here because I just think we'll be here all night. But it makes sense that a neurologic disorder could actually trigger the development of FND based on those changes that occur in the brain. So not totally out of the possibility that a craniotomy could trigger FND. But I, of course, would not, now I'm not a physician, so I don't diagnose, but if you came to me and you said, oh, I was diagnosed with FND after a craniotomy, I'd be like, that's interesting. Let's do our whole neuro exam. Let's really screen. I want to confirm that it is indeed FND. I'm looking for those positive signs. Oh, thank you. The buffalo, the BCTT, of course. You know, I saw BCTT and all I could think of was body weight supported treadmill training. That is dating me because I worked on a huge trial post-stroke many years ago. I love the buffalo concussion treadmill test. I love it, and I love the versions of it in for marching and bike tests. I love using that as a way to get a baseline for a person's autonomic regulation as well. Obviously, it was designed for concussion, but we use it in FND, and we'll use it actually to, or we won't always use this, but we might do a lower intensity version of it to get a baseline for graded exercise with POTS as well. I want to say hello to Callie. I got to see Callie in person. Somebody else is sharing that they have PNES, and I'm going to just share with you that PNES, which stands for psychogenic non-epileptic seizures, is a term that is phasing out because it's inaccurate. Not everybody with PNES has seizures that are psychogenic or psychologically triggered. The better term to describe what's actually happening is a functional seizure, because for some people, they're sensory triggered or even autonomic triggered. They are not psychogenic. So I'm going to give you a new diagnosis. Whoa, I'm so sorry. I tipped completely upside down, but I would call it functional seizures. And that is something that they discussed at the most recent Functional Neurologic Disorder Society meeting as the more acceptable term, because psychogenic is inaccurate. Great question. Oh, Julia, this is a great question. Does FND make you more prone to having POTS? This has not been proven anywhere, Julia, at all. So, and as the authors taught, that the authors specifically talk about that in the literature, at least, they're not even seeing these alongside each other very much. But anybody that has been to reactive, anybody I worked with, again, we see them maybe like a 15% together. And I'm just going to give you a hypothesis. It's not founded in the literature at all. But what is in the literature is that FND could be triggered. And I think that for some of the folks that we see with FND, that they weren't diagnosed with POTS, and we find that they have symptoms of POTS, and we recommend the diagnosis, and we do some of the screening, or we recommend them go get screened by a cardiologist to get the diagnosis. I think that they probably had POTS, and they might also have hypermobility, right? Because we know those two go hand in hand. And together, those can cause changes in the brain. The sensory information from our body. So for example, in hypermobility, we might not be getting accurate sensory information and sensory feedback that can cause functional motor symptoms, because our brain is not updating its feedback loop, for example. So that so I went and I added another layer to your question, Julia, because I kind of added in the hypermobility component too. Not everybody with POTS has hypermobility. Not everybody with hypermobility has POTS. So I don't want anybody to make like some gross leaps there that like this is always all the time together. But it makes sense to me that potentially a person had POTS first, undiagnosed, and maybe had hypermobility, again, undiagnosed. And that could have led to the development of FND. There are 0 papers sharing this. There are papers, however, that are suggesting this because of how common or how much more frequently hypermobility and FND go together. There's not a paper on this in POTS. I think we need to publish our data from Reactive because we are certainly seeing it. But again, because we're a specialty center, again, we have an FND program. We have a POTS program. We have an EDS program. We see some of the most complex cases because we have an entire team, PT, OT, we have speech therapy, by the way. I'm so excited about that. That's brand new. Speech and psychology. So we might be seeing the most complex cases compared to your general outpatient practice. But to answer your question, I don't think, and I don't know of any reason why having FND might make you more prone to POTS. And again, POTS has very clear diagnostic criteria. Now, going back though, Julia, to that article, we do know that people with FND might have autonomic symptoms. So there may be autonomic symptoms. I do think that people with FND may have autonomic symptoms. That's been shown in the literature. I don't think having FND predisposes you to having POTS. Very different mechanisms. But the reverse might happen, right? But we don't know. I'm just kind of hypothesizing here. Really, really great question. Yeah. Oh my goodness. I guess my phone I'm so sorry. If you weren't dizzy already, you might be. I guess I'll hold my phone still. I guess it's loose here and it's just flipping upside down. I want to give you a little correlation. 3PD, persistent postural perceptual dizziness, is a clear disorder with clear diagnostic criteria, and it is a functional dizziness disorder. It occurs after an acute dizziness event, like a vestibular neuritis or BPPV. And that has a very clear trajectory, right? You have a vestibular event, your brain and your body maladapt afterwards, and you develop 3PD. We can think of the bigger umbrella of FND as a similar thing. You have, let's use Oliver Sacks for an example. You break a leg, you have a knee injury, you have a broken bone. You have brain and changes that occur due to that, and you might, like Oliver Sacks, develop FND. So is it possible that somebody has multiple sclerosis and some of those brain changes lead to the development of FND? It is. Is it possible that somebody has POTS and subsequent changes could lead to the development of FND. And I'm not just saying POTS, but literally any type of disorder that could cause changes to the brain could lead to development of FND. Now, does everybody with POTS have FND? No. Is POTS FND? No, that is the point of the paper, right? But could we see these coexist? Yes. Okay, let me see. I feel like my phone is stuck here. And I'm not able to scroll through your comments. I am so sorry. Let's see. I'm going to just try something here. And I just commented myself. Okay. I guess my comments are stuck. So I am so sorry that I think my phone is kind of stuck here. That if you had another question or comment, let me know. You could type it in here again. It just looks like I can't scroll through them, but I apologize because I know there were some really great questions or comments. Somebody did submit one question ahead of time that I wanted to get to, and then I'm going to share one more article. And oh gosh, I hope I can pull this up here. I had several articles pulled up that I was looking at, and now let's see if I can find them. But so maybe I will just remember this off the top of my head, is that one person asked me, oh, here it is, what to look for in heart rate variability and when it shows someone has autonomic symptoms or impairments. And this was from Sydney Wren, maybe. So thank you for the question. So this is a really nice overlap of a assessment and treatment tool that you might use in POTS and you might use in FND and many other disorders, but that's to look at heart rate variability. So we look at heart rate variability on assessment, and we look for how it might change as the person's doing activities, as they're changing positions. And particularly, we're just comparing the person to themselves and looking to see, do certain things increase their heart rate variability, which would be great, or does it decrease their heart rate variability, which is what we don't want. And so we will establish a baseline, and then we'll go through treatments, and it's really helpful objective data to give us feedback. It is not diagnostic. So it's not telling us that a person has dysautonomia. It's not telling us that they have POTS by any means, but it's giving us an overall picture of their nervous system regulation. Great question, Brenda. We use a polar monitor, or we use the Leaf monitor. The Leaf is a portable EKG. Both are chest-based monitors because that is the most accurate. And what is nice, if somebody does have an autonomic disorder, this is going to give us some feedback and baseline for them. And as we go through some training, we're getting objective feedback about their heart rate variability. What's also nice is that we use those monitors for their heart rate too. So somebody else asked a question of what would be the treatment for POTS. Now, I'm going to have to say, we're going to have to do a whole episode, I think, on POTS treatment, and maybe I'll bring in our POTS program manager for this. But there are some really great evidence-based lifestyle components for POTS, whether that is compression wear or changing the diet. There are medications that are helpful for POTS, and graded exercise. So there's a lot that we can do for the person with POTS. Now, I say that, and as a physical therapist, I think we do need to be careful, and we need to screen to see if a person has ME/CFS and post-exertional malaise, because even our traditional graded exercise progression in POTS can be contraindicated. So I just want to put that out there. It's not an end-all be-all for everybody. Somebody else asked, and again, I'm so sorry because I can't scroll through the comments, so I'm trying to catch them as they come through here. What position do I do baseline testing for heart rate variability? This is very specific to the person and what we're doing in therapy. So if I'm going to do a task, let's say in sitting, we'll do a baseline in sitting, and then we'll add in components of that task. If I'm just trying to get an overall baseline of heart rate variability, I will do it in supine. But here's the thing that we have to think about with heart rate variability and the autonomic nervous system in general is that so many things influence it. Where am I in my menstrual cycle? What time did I wake up this morning? Did I have coffee? What did I eat, right? So in the studies looking at heart rate variabilities, those things are very, very controlled. In the clinic setting, we don't control those as much. So I think this is why, for example, we kind of use a person's status as their own baseline. Gigi loves physics, which, oh my gosh, I love physics. So I love that handle for you on Instagram. Says, love that you're screening for ME/CFS and post-exertional malaise. We all should be screening for that, right, Gigi? Especially in a person with autonomic symptoms, especially with a person who's not tolerating exercise or activity or getting worse with physical therapy. Like, that's a big red flag for me. Like, we got to screen this. And there's absolutely, again, there is a starting place. Nervous system regulation is really helpful for that. Oh no. Okay. Shira's saying, I feel like rarely do people screen for ME/CFS. I had a PT today and my body is dead. Oh, I'm so sorry, Shira. People should be screening for it. It's part of what we do for screening. And I will say, you know what? Sometimes we are learning together. Me as the PT, you as the patient, you don't know your limits. I don't know your limits. We're going to monitor it. Sometimes we might not get it right. It doesn't mean it's over for us, right? So I'm saying that in just full transparency. Sometimes I've done too much with a person. Sometimes they're dead next day. Sometimes it's a whole week and we go, oh, well, we learned from that, right? We learned and we're going to do something differently, okay? Like, we know we need to get a baseline. We know we're going to monitor heart rate. We're going to monitor rate of perceived exertion. We're going to start in a different position. We're going to do more nervous system regulation. So don't give up on your PT. I'm going to tell you, I learned so much from my patients. They bring such wisdom to me, and it goes back and forth, right? So we learn a lot from them. Alyssa is asking, do we use the CHOPS protocol? So I'm going to tell you my favorite protocol is the Utah ADAPT protocol. You can Google it. You can download it. The reason I like the Utah ADAPT is they have a component of graded exercise that's a kind of pre-start to graded exercise that is for people with ME/CFS and post-exertional malaise. That's why I like the Utah ADAPT protocol. The modified CHOP, so there's the CHOP, Children's Hospital of Philadelphia, and now there's the modified CHOP. Also a great protocol. We've used that as well. Yeah, Alyssa, go check it out. Just Google Utah ADAPT protocol. Really great resource for exercise progression. And once again, someone else made a comment, and I'm so sorry that Shira, I think you made a comment, and I can't scroll up in my comments, so I can't catch it. But I want to encourage my fellow clinicians, again, if somebody is diagnosed with FND and they're having autonomic symptoms, it doesn't mean they have POTS or an autonomic disorder, but you should absolutely screen for the presence of those disorders. POTS is not FND. Dysautonomia is not FND. And there's very clear diagnostic criteria. And there's very clear things that you can do as a physical therapist or OT or a speech therapist. And then finally, I'm going to give you one more resource here, because we published an article just in October, and we published this because we've been listening to you. This was for neurologists. We gave very specific recommendations for clinic-based assessment and treatment strategies for people with FND. And as a part of this article, we gave this diagram, and we asked them to screen the autonomic nervous system, and we asked them to do an active stand test and refer people for diagnosis and treatment. So you can share this article too. It's great for neurologists. I just wanted to share one more resource for you. And Gigi Loves Physics also says pre-MECFS post-concussion exercise meant I felt better cognitively after. However, one of the first signs that I had ME was the treadmill test gave me brain fog or cognitive symptoms after. Really, really helpful to know. And there's so many pieces of that, right? I also would say post-concussion and treadmill tests, vestibular system, and overstimulating the vestibular system could also cause the brain fog, right? And so this is where it's so multifactorial. Anytime that we are seeing symptoms with a person with testing, we want to look at all of the systems that are coming together with that, right? So there's the cardiovascular system, there's neurologic system, vestibular is a big part of that, sensory is a big part of that, visual is a big part of that, right? So all of those components can come together to influence our symptoms. When we see that, when we see post-exertional malaise and some of those symptoms, again, we want to zoom out and see what might be contributing to that. Because frankly, we want people to live well with these disorders, right? And I believe very strongly they can be managed and people can live well. Lisa's happy. Where can I find the article that you wrote? Let me share it again, and I'll put it in our newsletter. So if you're on our newsletter, I will share it again, but this is also free full text. It's in Practical Neurology. It's called Clinic-Based Assessment and Treatment Strategies for Functional Neurologic Disorders. It's written for the neurologist, and in this article, we say, hey, you better screen for POTS, and you should do an active stand test and refer people because it is a NOT FND. So I just want to say these authors and our team, we are in agreement. So boy, we've been chatting for a very long time, and I just want to thank you for hanging out with me, for sure. Oh, Lisa, you're Indy's mom. What the FND's mom? She just graduated today. Oh my goodness, I'm so glad you're here. What an absolute pleasure. I'm just going to share for everybody that we love working with the people that we work with. We love the families that we work with. They give so much, and work so hard. And so anyway, just thank you, Lisa, for being here. And I know I got to meet you in person, so thank you. So just to wrap us up here, this is the article, the opinion piece in Frontiers in Neurology that we reviewed today. POTS and other autonomic disorders are not FND. You might see them together. You got to treat both of them, and you can treat and manage both of them. So that is our message for today. We packed in a lot. We shared a lot of articles. I'm going to share these in our newsletter this week. Thanks, Susan. Hey, great to see you. Educational as always. You are so welcome. I am so passionate about this, and I'm so very excited to share anything that comes my way and to answer your questions. So again, if you are a patient and want to get on our newsletter, get all of these resources, you can sign up at reactivept.com/newsletter. You can comment newsletter on our posts and we'll send you the link. If you're a clinician, you can go to reactiveeducation.com. And hey, if you are a patient who is experiencing POTS or EDS, we created a guide based on years of experience in all of our patients on compression wear. So you should download that guide. It is on our Zebra webpage. But if you comment compression, also we'll send you that guide. Our POTS and EDS program director just created that guide, and it is fabulous. It's so good. So thank you so much for joining me tonight. And I just love that you're curious like me. So just keep staying curious and we'll keep learning together. All right. Have a good night.